everyone. Welcome to this event. I'd like to just quickly introduce myself and introduce O20 before we get started. I'm Lydia. I'm the head of human development at O20, and O20 is essentially a political party that utilizes progressive pragmatism to achieve our goals. And of these aims, we especially value increasing diversity, helping students with housing, and connecting our peers with jobs and internship opportunities. So we don't only focus on matters directly relating to university education, but also on matters that will improve students' prospects after finishing their studies and moving on to their professional careers. So if you're interested in joining us, we've extended our deadline for our candidate applications. And as always, we're on the lookout for anyone to join as an active member. So if this sounds like something for you, please don't hesitate to get in touch with me or contact us at hd@o20together.nl. And on behalf of everyone at O20, we sincerely hope you enjoy this lecture this evening. So without any further ado, I'd like to pass it over to Eunice, and Eunice, take it away.
Thank you. Hello, everyone, and welcome to the first event in O20's Mental Health Week. My name is Eunice, and I'm a communication science student at the UVA, and I'm very excited to be moderating today's event. First of all, before we begin, I'd like to introduce Mr. Ziad Kronfol, who will be giving a lecture on the differences in mental health between the Western world and the Middle East. Mr. Kronfol is a professor of psychiatry at Weill Cornell Medicine in Qatar and has published several papers focused on mental health in the Middle East. Before I hand it over to Mr. Ziad, I would like to please ask all participants to keep their mics muted and preferably, of course, have their cameras on to increase the engagement. Following the lecture provided by Mr. Kronfol, we will open up the floor for some questions. And when it's time for that, we'd like you to please send them in the chat so we can communicate them to our guest speaker. Now, without further ado, I'll be handing it over to Mr. Ziad, and thank you.
Thank you, Eunice. Let me make sure that we can proceed. So, do you see my? Do you see my presentation?
No, not yet.
Not yet. Okay, let me go back and see why not.
Have you pressed share screen?
Okay, wait a second. Let me go. Okay, so share screen. And this is, I suppose, my presentation.
Yes.
And now I can get started. Let's see with the first slide. I need to find the...
Go to slideshow on the top. Yeah, and
wait a second. Usually it's at the bottom and I put this big screen. All right. Do you see it? No, because I didn't. Okay, so new share.
No, we can.
We see it.
Yeah.
Okay, you are seeing it?
Yes, yes.
This is this is the first slide?
Mm-hmm.
Okay. Yep. So should I put share?
Yeah, I think you can just get started.
You're seeing the first slide? Okay, so let me just remove. Okay, so yeah, so the title of my presentation, you hear me and you can see the slides, right?
Yes.
Okay, so the title of my presentation is Psychiatric Illnesses in Different Cultures. It's a personal perspective. I decided to give this title because it is not a lecture that for medical students that they're going to be quizzed at the end and pass or fail or whatnot. I just wanted to share with you my own feelings because I've been, I've been practicing psychiatry for several decades, and I have my own thoughts. So a lot of what you're going to hear are my own personal feelings about it. If you agree or disagree, that's fine. We can always talk about it. But this is not something that is very standard. I mean, other people might have different points of view. Okay. So I just want to start by saying that I don't have any commercial interest in my presentation. I'm not trying to sell you anything. I don't have any conflict of interest. We're supposed to do this for any presentation. So the goal of the presentation is going to be as follows. First, I'm going to talk a little bit about myself, who I am, why did I choose psychiatry, some of my major career milestones. I hope it's not going to be very boring. And then I'm going to talk mostly about individualist versus collective cultures. This is basically the differences between cultures. I'm not going to go into each and every single culture, but in general, some cultures are more individualist than others, and we'll talk about this. I'll give you some presentation about specific psychiatric disorders and give you an example of how a patient, in Europe or in the Middle East might present with this illness. Then I'll conclude with some ideas of my own and a look at the future, and we'll have some time for questions and answers. Okay? So who am I? This is a question that puzzled me for a long time. I'm sure each one of you have asked himself or herself this question. I was born in Lebanon in the late 40s, early 50s. At this time, Lebanon was called like the Switzerland of the Orient. It still is very beautiful, mountains, and people come to ski in Lebanon, the beaches. It's a very diverse society, the tourism, banking, etc. Unfortunately, this has not always been the case. This here is our house. In the 1930s, you can see there is a lighthouse behind it. We were close to the sea, and see here there was a goat. So it was sort of pretty rural. This is the same picture. This is the same house and the same lighthouse, but this picture was taken more in the 50s and 60s when I was a child. So I remember very well, this part of Beirut, where I was born. So as a child, I don't think there was anything peculiar about my childhood, except that I went to a French school, so I speak French very well. I was, my teachers used to call me le petit philosophe. The reason they do that is because for some reason I had all the problems of the world on my shoulder. So I would ask questions like, what's going to happen after we die? Or, where do we come from? Or, where is God? Things like that. Whereas most students are having fun, playing. To me, it was like, I worried a lot about these questions. This picture is taken. I went to international college. This is the college that I went to, 58 to 67. From basically primary through high school. It's an international college, so there were a lot of students from different countries, and they teach in French and in English. My parents, for good reasons, put me in the French section. And, I grew up being exposed to the French culture. We were a lot exposed to French literature, Cornell, Racine, Molière, French philosopher, Pascal, Descartes, Jean-Paul Sartre, etc. These had a lot of influence on who I am. This picture is, I was sort of a little bit shy and aloof, but I always pushed myself. This picture is, I participated in a competition for poetry. And, I think I got the second prize, but this is not the reason I'm showing you the picture. The reason I'm showing you the picture is that, I was terrified, absolutely terrified of public speaking. And when I was standing here and I was giving my speech, it's like, the amount of anxiety that was going on internally, just being in front of people on the stage was, absolutely overwhelming. It was so much so that, when we were exposed to Descartes and, like, I think, therefore I am, to me, it made a lot of sense. Of course, we are thinking all the time. So if you think, then you are there to, you obviously you're alive and this is who you are. But for me, I twisted it a little bit to apply it to myself. I changed this to, I'm anxious, therefore I am. Because to me, like, the only way you can be present, assert your existence is through anxiety. But anxiety for me was not necessarily something negative. It was mostly like, thinking about the future in a constructive way. What am I gonna do, to make myself better, to make the world a better place? Of course, it's worrisome, but it's also, something positive. So we went to in high school. At some point, like before I graduate, you have to. I don't know how it is in the Netherlands, but in France, you have to choose between, in my days, littéraire and scientifique. So you have to change a path either in the science or in the arts. And for me, like I definitely wanted to go in the arts because I was very much into psychology and philosophy, and I was asking myself all these questions. But I wasn't sure, I mean, my family had, I mean, most of my friends went into science, engineering, math, and so on. So I decided, that I was going to go into the philosophy. And I, got my last year in high school was in philosophy. And this is where I was introduced to Freud. And, I mean, this is where I was introduced to psychology. And I really liked it. And I remember I told my dad, like, he asked me, what are you gonna do for a career? And I said, philosophy. And I was very enthusiastic. And he told me, yes, son, but you have to put food on the table. And I remember that although I argued with him, food is not important, what's important is to be happy with your, who you are, etc. But I really took it at heart, and I decided to enter medical school after doing philosophy. This wasn't easy at all because it's very competitive in pre-med. And I mean, most of the students that I was competing with for medical school had background in physics and chemistry and biology, and my background was in psychology and philosophy, and I had to compete with them to be able to enter medical school. Needless to say that it was challenging, but I did it. And then it was 4 years of medical school. I would say that it was a little bit of a struggle in the beginning, but every time we approached the nervous system or something that has to do with the mind-body issues and so on, I was very, very happy. And the challenge for me was when you before you graduate, you have to spend time in the emergency room, at the operating room, and start doing all these procedures. They were scary for me. But I, learned to, accept challenges and, push myself to do things even if I don't like. So eventually I graduated and I chose psychiatry as a career. I had left Lebanon and I went to the University of Iowa in the USA. This was a very good department in psychiatry. It was sort of like biologically oriented, but I learned the rigor of psychiatric diagnosis and, the basic science for psychiatry. But this was in the mid 70s, and the beautiful Lebanon that I left, there was a civil war. And the civil war actually was, very bad, and it was very protracted. Every day we think this would be the final battle and it will end, and it lasted for like 15 years. And, like it's estimated that 200,000 people at least died. And honestly, I don't think that we're through the consequences. But this affected me because I wanted to go back to Lebanon and teach psychiatry, but I couldn't. So I had to change path. So I joined the University of Michigan in Ann Arbor, and it was a very it was a prestigious school. I was there. I started there as a fellow, a research fellow, and then I was on the faculty for many years, 1979 through 2006. But this is where I did most of my research, where I see most of my patients, where I developed as a psychiatrist. So I'm going to tell you a little bit more about a couple of things that I was interested in. Although I was very much interested in philosophy before entering medical school, but once I got into psychiatry, I was really interested in the neuroscience. How does the brain work? And just to give you a little bit of a perspective, one of the things I was interested in is the relation between the brain and the immune system. I mean, now you take it for granted. People talk about how stress affects, your immune system, but this was in the 1980s, So, and I was working in a place where they were working on depression, and I was, among the first people to propose that, if you have stress and depression can actually affect your immune system. So I worked with, different people, and we did some measures of immunity. This was published in 1983. What you have these are some measures of immunity, and what you have on the left-hand side is, like for normal people, this is function of lymphocyte. This is the function of lymphocyte on people with depression, mild, moderate, and severe. And we did show at the time that actually people with depression have some sort of impairment in their immune function. Since then, we've done a lot of work looking at, the effect of which hormones are affected, what are other psychiatric disorders that were affected, et cetera, et cetera. But for me, this was my major contribution to the field. And with time, we were able to publish our work in a prestigious journal like the American Journal of Psychiatry, etc. This is just one slide that we published in the year 2000. This is more than 20 years ago, but it shows here how psychological stress and physical stress. Physical stress here is like if you have an infection or trauma, both of them, can affect the brain and the immune system. They can affect the brain by, secreting some hormone that can affect immune function, and that the immune system itself, under stress, can produce cytokines that affect our behavior, like sleep and appetite and so on. So this was at the heart, if you want, of stress and immunity. And now we talk about the role of stress in predisposing for cancer and HIV, and now COVID and all of these things. But all of this, we were talking about even like 20 years ago. I don't know why I'm not able to go to the next slide. Okay, so I'll hold on with me a little bit. I'm having problem going to the next slide. Okay, so this is the time when the beginning of the 20th century. I started to get a little bit tired of research.
Sorry to interrupt. I think your slides are not being shared anymore.
Okay, so let me go back here. This is the slide. Okay, so I need to put show slides. What am I supposed to do?
Yeah, so at the bottom of Zoom, I think there should be a share screen button in green.
Okay, except that I don't see it. Let me go back here. Oops, we got lost. This is my slide presentation. You don't see the slide.
No, I think before you have to go back to your Zoom tab, and then press share screen, and then
share screen and press here. Okay, and share. Do you see anything?
Yes, now we see your screen.
Oops, no. Yeah, let me give you this. Yeah, this is the slide that I wanted to show. All right.
Yes.
So yeah, so this is the time then the war in Lebanon was coming to an end, and there was more hope, and I had family there, so I went back to Lebanon, but I still find it very unstable. So I went to Doha in Qatar. I was impressed. It was a country that is progressing very rapidly in terms of construction and building the infrastructure, and Cornell University had a branch. It just started, and they were, so we started to build psychiatry in Qatar at Cornell. And this is a picture of the campus over there. This is like one of the auditorium and so on. So I moved to Qatar in 2007, and but I continued my work with Michigan, as an emeritus person. When I moved to Qatar, the first question in my mind is, how different are going to be the patients? Because I remember, the patient that I used to see in America, I thought that it's going to be very different in Qatar. The fact is that, as you can see, there is, they deal with mental illness. The incidence varies from basically 10 to 20%. So 10 to 20% of the population worldwide suffer from some sort of mental illness. And frankly, it wasn't that different. what was different for me was, the culture, because I was used to US. It is an individualist society, but Qatar and most of the world actually, were more like collectivist society. And I don't know to what extent you know the difference, but I share it with you because it seems to me that it might be interesting. So individualist societies, they value individual achievement. Collective societies, they value collective achievement. In individual societies, you set goals for yourself. In collective societies, you practice allegiance to the group. Competition with others in individual societies, harmony with others in collective societies. You do what is best for the individual, in the collective society, you do what's best for society. Individualist societies, they value independence, what's unique about the individual, whereas in collective societies, they value interdependence, the values that are shared with others. Individual societies, they want autonomy. Collective societies, they respect hierarchy. In individual societies, success is measured with money, goods, fame. In collective societies, its success is measured more with sense of belonging, sacrifice, duty, etc. And then, on the negative side, if you fail in an individualist society, you express guilt for not achieving your goals, whereas in collective societies, it's more like shame for, by being ostracized by society. So this is something that, I didn't learn about it in a lecture, but by seeing patients, I realized the difference. Like the first patient that I saw when I was in my training in Ann Arbor, the patient was brought to me by the family because he was, 20 years old and he was still staying at home, and he was not paying rent for his family, although because he was living with the family. And for me, it's like, well, there's nothing wrong with that, but I didn't tell them that. This was considered abnormal. When I came to Doha, I had people come to me, the complaint, well, my son is 20 years old and he wants to leave us. He wants to live on his own. There is something wrong with him. Please help us. So, you see the difference. So, again, I'm looking at the literature more recently. People have looked at this in terms of collective society, but in general, the only countries in the world which collectivism, is, most societies actually are collectivist societies. The countries that are not are mostly, North America, Australia, and part of Europe. But even Europe, like Italy, Spain, family, La Mama and Italy is a very important entity. So what I'm going to do right now is give you some examples of cases, like psychiatric cases. Let me go back. So depression, for instance. Do you see the slide? Hello?
Yeah.
Yes, you see the slides.
Okay, you are seeing this. So like in cases of depression, the common features of depression are like sadness, decreased interest in pleasurable activities, changes in sleep and appetite, feelings of hopelessness, guilt, and suicidal ideation. So like these are not patients that I've actually seen, but I made that up because I think it's sort of a reflection of, after seeing so many patients, you have an idea of what would be the problem. So like in Ann Arbor, an example of depression would be a 58-year-old woman. She loses interest in her work, sees herself as a failure, no longer interested in playing bridge with her peers, feels guilty about it, overwhelmed with feelings of hopelessness. She contemplates suicide. She seeks help from a therapist. The same situation in Doha, like 58-year-old woman, she would be not complaining of sadness, but coming up with what we call somatic complaints: insomnia, recent onset of headache, fatigue, generalized weakness, back pain. She could no longer do her daily prayers. She thinks she will be punished for that. She blames the evil eye, some sort of superstition for being sick. She thinks about talking to a spiritual leader. So this is like an example. The disease is the same, it's depression. but how it manifests, and differently in Ann Arbor and in Doha. Same thing about schizophrenia. So like, the common features are delusional thinking, auditory hallucinations, bizarre behavior, gradual decline in functioning. In Ann Arbor, an example would be a 26-year-old accountant left his job complaining that the IRS put a chip in his brain that transmits data on customers directly to them. He hears people talking about him and mocking him, believes other employees are part of the plot. The situation in Doha, it would be more likely like a 26-year-old construction worker left his home in Nepal to make a better living in Doha, hear voices in his head telling him that his fiancée, Mrs. A, is having an affair, believe the government in Nepal is involved to make him return home. Turns out, when we inquire more about it, we try to contact, his fiancée, she's never heard of him. There's no such thing as his fiancée. Then you have anxiety. Common features of anxiety, as I'm sure you all know, includes excessive, sometimes unrealistic worries or fears that last over time, physical symptoms such as difficulty breathing, heart palpitation, a choking sensation, or feeling that something terrible is about to happen. In Ann Arbor, you would have a 43-year-old woman with excessive worry about her work. She is like, an executive in a firm. She worries about her finances, her appearance, her health, her role as an executive, an independent member of society. She has concern about her personal achievement, and she feels guilty for not, being up to the standard. In Doha, a woman with anxiety, same age, would have excessive worry about her family and relationship within the family and her role as a caretaker. Am I taking good care of my husband? Am I taking good care of my sons and daughter? Am I good with my neighbors? She's afraid of punishment and issues of honor, shame, etc. Mania, bipolar disorder. Common features are extreme happiness or irritability, excessive energy, rapid speech, grandiosity, excessive spending. So in Ann Arbor, you have a 19-year-old college student. Ann Arbor is a college town, so we have a lot of students. A 19-year-old college student, previously an A student, stopped attending classes, bought himself a guitar, believes he's a rock star, practices day and night, thinking he will be nominated for the Emmy. In Doha, you have a 19-year-old college student, again previously an A student, stopped attending classes because he thought he was chosen by God to spread the message of the Quran, spends day and night on the computer spreading the message on social media. And last but not least is like an example of PTSD, post-traumatic stress disorder. Common features are irritability, hypervigilance, difficulty concentrating, flashbacks, avoidance behavior following an experience of major trauma. So in Ann Arbor, the major trauma, sometime would be something like a 32-year-old woman once experienced sexual assault in a park, has flashback of her experience every time she is close to a park, avoids ever being alone near a park, and she refused a lucrative job offer because her office overlooks a park. So she wanted to avoid the park because it reminds her of her situation. In Doha, you would have a patient with PTSD. It would be a 32-year-old woman refugee from war-torn Syria, has a startle response and flashbacks of gunfire every time she hears a loud noise. She left her job as a cleaner because it was close to the airport with frequent loud noises of planes landing or taking off. So these cases basically give you an illustration about the disease and how it's manifested differently in different cultures. And I think with the background about collectivist versus individualistic cultures, it puts things a little bit in context. So in conclusion, for these cases, the general outline of the illness is the same, but the manifestation of the illness may vary depending on the culture. And again, theories about causes and consequences may vary. Like, in the case of depression, in Doha, they think it's the evil eye. In Ann Arbor, they think it's a chemical imbalance in the brain. And treatment options may also vary, whether you use psychotherapy, medication, or you go to the spiritual healer, and so on. So after being in Doha and after having done a lot of biological research, I was interested more in things that I could see around me. For instance, I was doing much more teaching than I was when I was in Ann Arbor. So we saw a lot of patients who were immigrants, who were workers coming from Southeast Asia, blue-collar workers, and they had some mental health problems, and these mental health problems were never discussed in books, like in the West, in the US or in Europe, I suppose, because they don't have this type of people. But in Doha and the Gulf, there are many people who are workers and who have mental health issues. So working with the student, we went over a series of some of these cases and we published them. Okay, so again, I'm having trouble. Do you see my slide?
Yeah,
yes.
We can see.
Okay, so and then many of my students in Doha, were coming from areas of conflict: Syria, Iraq, Yemen, and I could see, I could see them in class, but I know like every day on the news, we know about their country being torn apart, people dying, famine, immigration, terrible things happening. And then they can never study the effects of war. There's in the curriculum that we were teaching them coming from Cornell, there was nothing about psychological effect of war. So we had to invent. So the student did a very good job at reviewing the literature and coming up with their own presentation. So we had published about psychological effect of war, a role play. So we had students coming from different countries in a conflict situation, and each one of them had a role play about a psychiatric disorder like anxiety or suicidal ideation or depression because of warfare. And again, they made a YouTube that is now published that you can refer to, that you can see about their own contribution to the literature. And because I was spending so much time with students, I wanted to know a little bit about the type of stress that they experience. And I suppose this a little bit like you guys. The data from the US is something like 80% of students feel overwhelmed by their responsibility as student. 50% have struggled with anxiety. 50% have felt that their mental health is below average, and some of them has considered suicide. But this data comes from the US. Like 80% have report stress, 13% report depression, anxiety, and 9% express suicidal ideation. I wanted to know how it was like in Doha, because we have a very international type of students. The majority of our students actually come from other Arab countries, or the India, Pakistan, Nepal, Sri Lanka. And again, there is a lot of poverty, there are a lot of conflict in these countries. So we decided to make a study. In our study, we compared 4 different campuses. One of them is Education City, where Cornell was located in Doha. The other one was a more conservative Qatar University. It was a more conservative university in Doha. The third campus that we compared was the American University of Beirut, where I studied. The American University of Beirut is a very old university. It was established in the 1860s by Quakers, and it's considered a very liberal, American institution in the Middle East. And then we compared all of this to University of Michigan, Ann Arbor. So we gave an anonymous survey about mental health that the student could confidentially and anonymously fill online, and we compared the data. And this paper is published in BMC Psychiatry. This is the title: Selected Psychiatric Problems Among College Students in 2 Arab Countries, Comparison with the United States. The major finding is that, this is like major depression, this is generalized anxiety, and this is eating disorder. And this is, how the number of students the percentage of students who, meet criteria for major depression. In red, it is the Arab countries, and in blue, it's the USA. So we found that all the Arab countries that we compared, the conservative and the liberal universities in the Arab world, the students reported much higher frequency of depression, anxiety, and eating disorder. And when we looked more closely in the data, let me just put this. Yeah, can you see the slide here? Hello?
Yes.
Okay, so I'm gonna help you a little bit with the slide. It gives you odd ratio. This is for depression, anxiety, and eating disorder. So we looked at what is contributing to the higher risk of depression and anxiety in all of these students. And we found, for instance, like, being a female, and once you have the odd ratio more than 1, it means it's higher than normal. Below 1 is lower than normal. So like, being a female in all of these countries contribute to depression, anxiety, and eating disorder. Being a graduate student, for instance, it decreases the anxiety a little bit, but it doesn't really have a lot of difference on like depression. Financial problems, when finance is a struggle for the student, then this definitely increases their odds of having depression, anxiety, and eating disorder. Being in a relationship apparently did not make a lot of a difference. And again, for low GPA, the low GPA increased the odds for depression and anxiety. But also, very interestingly, being religious, fairly religious or very religious, seems to also decrease the odds for depression and anxiety. So again, we were trying to figure out, what is contributing to the higher rate of anxiety and depression in these countries. I think I am coming close to the end of my presentation. So basically, what I want to tell you from my experience, and again, as I told you at the beginning, it's my own. When you look at differences among countries and among cultures, the differences are not, there are differences in manifestation, but the disease process is the same. So I wanted to finish with this saying, the French saying, plus ça change, plus c'est la même chose. And this is I found a cover of a CD, which is titled, and I think, there is a tree here. It's the same tree. You have different leaves, you have different fruits, but it is still the same tree. And my conclusion is that yes, there are differences among cultures, but basically we are all human, we are all the same to a large extent. And looking toward the future, I believe, and again, these are my own opinion, with the globalization, social media, and advances in neuroscience, the gap in knowledge between cultures is likely to diminish. Because you have the student, whether he is in Nepal or whether he is in Argentina or in Ann Arbor, they are exposed to the same material, the same amount of knowledge. Telepsychiatry is also likely to play a role as an important, in faraway cultures. So, you can now deliver mental health treatments to faraway places, which were, otherwise not accessible through telepsychiatry. And now there are all sorts of apps that are likely to play an ever-increasing role in monitoring symptoms and treatment. There are apps that tell you about how many hours of sleep. There are apps that monitor your heart rate. They can tell whether you are missing your appointment with the doctor, etc. And they're going to play a more important role in our lives. And I would also project that artificial intelligence will probably dominate and likely modify the way we live our lives in the future. Now, we started with, I don't know, like now you have Alexa, you have an intelligent car, you have an intelligent refrigerator, all things around us, they are developing some sort of artificial intelligence. And I think, our lives in the future, your lives, is going to be more and more dominated by, to what extent is artificial intelligence, included in your day-to-day life. This is the end of my presentation. I think I done this in 45 minutes. I know that my presentation reflects how I feel about things. Other people might see it differently, but I'm open to questions.
Thank you very much, Mr. Ziad. It was a truly really informational presentation. But if you have any questions, please send them on the chat below, and I'll be sure to be asking those out here. So our first question is actually from Dana, asking, do you think these cultural differences are considered when psychologists or psychiatrists assess treatment methods?
Yeah, of course. I mean, psychologists, psychiatrists, you have to do with what you've got. So like every person who seeks help, he or she have their own problem. It might be, as I said, it might be a problem that, the family is too overwhelming, or the family might be too much detached. So you have to tailor the therapy and the treatment to the individual person. And it's very difficult, sometimes when I ask for like referrals from the Gulf, wealthy Arabs who have some sort of a problem, and they ask, where should they go in the US to get the best treatment? And to me, it's like, well, the best treatment, I mean, anybody who's going to give you treatment needs to know about the culture, because it is not like one size fits all. You need to know the culture before you can develop the treatment. So yes, psychologists, psychiatrists have to be aware of the culture. But again, knowledge of the culture in and by itself is not enough. You really need to know about, the diagnostic methodology, the treatment advances, neuroimaging, what's happening in the brain, et cetera, et cetera. So you really need to know the basic science, and you really need to know the culture, and each, and modify the treatment for each and every single person differently.
Okay. Thank you for that. Our next question is from Emma, who asks, can you elaborate on the distinct differences between severe depression and bipolar disorder?
Sure. I mean, they are basically, first of all, the word depression is a little bit tricky, because depression refers to a disease, like any disease. It has its causes, it has its treatment, and it also refers to a feeling that each one of us at some point, will get depressed. I mean, if you have a low grade at an exam, you feel depressed, but it usually lasts for a few hours, and the next day you're fine. If you are an executive and you lose money, you are supposed to feel sad, but again, you don't get ill. So depression, when psychiatrists and psychologists use it, it refers not to a feeling, that is temporary and transient, which is a normal under the circumstances. It refers to a state of illness, something that lasts for days and weeks, or where you lose, you stop eating, you stop interacting with people, and it can be deadly with suicidal ideation. So you can have depression, major depression, and this is the great majority of depression, and it's usually more common in women than in men, but it affects about 10-15% of the population. This is major depression. Bipolar depression, it's part of bipolar disorder, which is much, it's not as common. It's maybe like 1% of the population. These are people who are prone to extremes of mood, depression and mania. When they are depressed, they look similar to the people with depression, but unlike the people with depression, they are also at risk of having highs, which are episodes of mania. And the highs also are not that I feel happy because it's a good day. The highs, they are also manifested by like you don't sleep for several days. You spend all your money. You made things that you tend to regret later. sexual indiscretion, excessive buying, etc. So it's sort of extreme moodiness, if you want. But the depression is the same. It is either part of major depression, it's also called unipolar depression, or bipolar disorder when there are episodes of mania or hypomania, in the mix. Other questions?
Yeah, another question from Malak. She asks, do you think mental health illnesses are a taboo in the Middle East? And if so, why do you think that is?
All right, yeah, that's an interesting question. Well, actually, they are taboo everywhere. And, it's only recently in the West that people started to talk about their mental illness be frank about it. But when I grew up, when I was a medical student, people were not open at all about mental illness. And it was a taboo. And I do remember, there are some people who would run for office, and it was published somewhere, it was found somewhere that they suffer from depression. So they would even become ineligible for the post. But things have changed right now, mostly because mental illness is so common. You cannot discriminate against 20% of the population for reason that is out of their control, and because some famous people came out and talked frankly about their mental illness. I know there are actors, there are politicians, who suffer from mental illness, the athletes who talk about their mental illness, so it's much more accepted. I think I can see the change. The change is much more apparent in the West, but I can see the change also in the, in Arab countries and developing countries. People now, the mental health program in Doha, for instance, has increased tremendously, and more people, go and seek help, and so to some extent talk about it. So I would only say that the development, the progress has been more apparent and more rapid in the West, but it's also catching up in the East and in the Arab world.
And then we have Zep, who asks, what would you think would be the most effective way to treat the large amount of war survivors from Syria?
Well, yeah, the war survivors from Syria, unfortunately, the tragedy in Syria is to some extent still ongoing. Not too many people are dying as several years ago, but the trauma, the displacement, the famine, the lack, the lack of education, and then many of these people are refugees in other countries. I know Lebanon has its share, Jordan has its share. I know there are some in Europe and around the world. These people are suffering, tremendous amount of mental health problems, and they are going to be traumatized for the rest of their lives, unfortunately. The best you can do is to offer them support to the extent you can. If there are some treatable mental illnesses like depression or anxiety, you can treat them with medication, but what they need is a sense of belonging, a new home, a new place to call home, a new country to where they can, develop and become useful citizen. So, and we need the help of, all agencies, the United Nations, the government of different countries, a volunteer organization, Médecins Sans Frontières, etc., etc. There is no easy answer. I wish I had the magic wand, but it's very important to be aware of their needs and to be able to give help them with their needs to the extent possible.
Yeah. And sort of linking back to what you were saying earlier, Sarah asks, how do you figure out the disorder if the symptom presentation differs between cultures?
How do you figure out the symptoms?
Yeah, so how do you figure out the disorder if the presentation of the symptoms differs between cultures?
Okay, so the basic things, let's take depression, for instance. When you are experienced enough, you would know that there should be some changes in what we call the biological features. Like your sleep is different, the appetite is different, uh, and the way you enter, the speed with which you think is different. So this, really doesn't differ very much from culture to culture. The sadness is the same, the despair is the same, the frustration is the same, the fear of the future, the negative thoughts is the same. What may differ is that, in some cultures, in Western cultures, it's okay to talk about, your fear and your sadness and your anxiety. In Arab cultures, it is considered, particularly for a male, for a man, to show this is considered weakness. If you say I feel sad, or I'm not very confident about the future, they tell you, it is a taboo issue. As I said earlier, taboos are changing and the barriers are crumbling. But if you, at this point in time, if you look at any cross-sectionally at this point in time, it's easier to talk about your mental health issues in the West than it is in the East. But it doesn't mean that in the East, they are presented differently. So instead of saying, I cry most of the day, you say, my back hurts all the time. And the psychiatrist and the psychologist who is in tune with the culture, he or she will be able to distinguish. They will tell you, okay, when you have this pain, are you thinking about something in particular? And they say, yes, when I have the pain, sometimes I'm thinking about, my son, he is sick or whatever, and then you will get to the bottom of it, and you will find that there is something that is causing this pain other than just, it's a osteoarthritis or something like that. It's usually a stressor but it's just disguised as, back pain.
And then we have another question asking, are there major differences in efficacy of treatment orientation? For example, CBT is well known to be effective in the EU and in the West, but does this change in a collective cultural context?
Well, I would say yes, but unfortunately there isn't really, I am not as confident saying yes because there are not so many studies. In the West, CBT has been studied for a number of years right now, and there are study after study that shows the efficacy of CBT versus other types of therapies or pharmacotherapy or whatnot. Unfortunately, these studies are not very much done in the Arab world, but from talking to people and my own personal experience, CBT is as effective in Arab culture than it is in Western cultures, but we don't have the data to show it, to prove it.
Okay.
Other
and then
questions?
Yeah, so Christine asks, you were mainly talking about universal psychological disorders. Are there any culture-bound psychological disorders in the Middle East?
I'm sorry, are there other what psychological disorders?
So are there any culture-bound psychological disorders in the Middle East?
Unfortunately, I would say yes. And again, this is because of all the trauma that our countries in the Middle East are subject to. If you look at a country like Yemen, if you look at a country like Syria, if you grow up in Syria right now, if you are a teenager, you have seen nothing but war. And obviously this is going to affect your brain development and your psychological well-being for the rest of your life. It's good that these disorders are not available in other countries, but I'll tell you, like, if you take COVID has affected every country in the world, and the mental health issues related to COVID are overwhelming all over the world. So these disorders develop depending on what's happening in a particular country. Again, if you take the United States, for instance, they don't have these problems with people who have been in wars, but you have the veterans who did fight in other wars, like in Vietnam or more recently in Iraq and so on. And there is a very high incidence of suicide, for instance. Something that people in Europe, people in other countries around the world, where there was no, where young men and women did not go to fight wars outside their borders, they don't have these type of problems. To some extent, it's related in what's happening in a particular country at any particular time.
And then, do you think cultural differences that affect mental illnesses should be taught to psychology students around the world?
Yes.
Yeah.
I know psychology is a very broad field, but if you are interested in clinical psychology, and particularly if you want to train to become a therapist or like a clinical psychologist, you are going to get, even if you live in Europe, or like take your country, Netherlands, for instance, you are going to have people who were born in a conflict situation and have immigrated, and they have problems. So you cannot, you have to be aware of the existence of these problems and how they are diagnosed and how they are being treated. As I mentioned, with globalization, no, you cannot isolate yourself and say, well, we don't see this here, because the world is changing and people are moving, and you never know what's going to happen next. You never know what the future is going to bring to you.
Yeah, definitely. And then our last question for today, just so we can wrap things up. Are Middle Eastern countries encouraged to foster an environment where these illnesses can be treated?
I'm sorry, you don't need my screen anymore, right?
No, you can stop the sharing if you'd like.
Okay, so I was giving all these answers, but you couldn't see me talking. So now yeah, okay. So what was the last question?
Yeah, so it's a question from Malek, who asks, are Middle Eastern countries encouraged to foster an environment where these illnesses can be treated instead of seeking it elsewhere, like in the US?
I would say yes. I think that, I take the example of Qatar, and also, like Lebanon. I know that the mental health field is growing intensely. I can give you an example, and this year we had the student who graduated this year, 2021. We have more students who applied to psychiatry than pediatrics, gynecology, and surgery combined. It is amazing. But it's a little bit, those numbers can be a little bit deceiving, because we have a very small class. And I'm talking about those who applied to the US for the match but my point is that a lot of students are being interested in psychiatry, in the Arab world. And I do know that although the government does not give a lot of money for mental health, but this is the same all over the world. Even in the US, the amount of money spent for mental health is nothing compared to like cardiovascular or cancer. Not to put these things down, it's other specialty, but I think that more money should be spent on mental health. I can see this developing, in the Arab world. It's a good thing that it's developing. But again, it needs more money. It needs more people, to devote themselves to the services, etc.
Wow. Thank you very much for truly all of your insight today. And unfortunately, we did run out of time. But before wrapping up, O20 and myself would like to thank you all for attending to this very informative event. And we'd also like to, of course, thank Mr. Ziad Kronfol himself for enlightening us on the subject of mental health in the Middle East compared to the West, and of course taking the time to join us today. Next to that, thank you of course to the O20 team who has worked very hard on this, and there are other mental health events that are to come this week. And if you'd like to keep up with our future events or what O20 is up to, be sure to follow our social media pages, check out our website.
Okay, thank you very much. Goodbye.
Thank you very much.
Thank you so much.